Thanks, Dr. Luke, and good morning, everyone. We have an excellent morning of speakers, and hopefully you'll enjoy it. I have the honor and privilege of introducing our first speaker for the morning, Dr. Sara Edwards. She is an orthopedic surgeon who specializes in surgery on shoulders, elbows, and knees. She did her medical training at Northwestern as well as her residency in orthopedic surgery there, followed by a fellowship at Columbia University in sports medicine. She previously was the head team orthopedic surgeon for Northwestern and also worked with the Cal Bears as a team physician there. Currently, she takes care of the San Francisco City College as well as the Oakland Ballet Group, and she will be talking this morning on women's health. So please give it up for Dr. Sara Edwards.
Thank you, Nick, and good morning. Can you guys hear me okay? I'm picking up? All right. And thank you for being here. It's nice to see everyone in person after a few years virtually doing this conference. And I kind of like this room because I feel like it's like the Wizard of Oz. We're hiding behind the curtain back there. Ignore the man behind the curtain. So today I'm going to talk about something that's near and dear to my heart, which is women's sports medicine, and do an update on women's health. And some of it's a review of what we already know. And part of my job here at UCSF has been to start a women's sports medicine center. So we're still in the initial infancy of that, but it's been very exciting, and we are working on the development of that as we speak. We have more female orthopedic surgeons and female sports medicine doctors here at UCSF than anywhere else in the country. So it's an exciting opportunity for us. Okay, it's my disclosures. Okay, so the female athlete. Since 1972 and the passage of Title IX, the number of female athletes has increased dramatically in the United States. Currently, it's at an all-time high. That's my favorite female athlete, by the way, Wilma Rudolph, who, if you don't know her story, you should read her story. She was a three-time U.S. Olympic gold medalist and world record holder in 1960, but she was contracted polio as a child and didn't walk until she was 5 years old, so she is quite an inspiration. From someone who had a significant disability to was resilient and came back. The first woman was admitted to the military academy in 1976, and it was noted at that time that there was an increase in overuse injuries that was reported in female cadets compared to the male cadets. And as they followed these military trainees, in a study in West Point in 1992 found that women engaging in sports had more lower extremity injuries than men, particularly stress fractures and patellofemoral pain. Many of the problems that female athletes face are the same ones that men face, but they just occur at a higher rate in women. So you're gonna see there's a lot of overlap between men, and I'm gonna touch on the primary diagnoses that occur much more commonly in women and why that is. We know if you look at overall sports medicine injuries, boys football has the highest rate of injury. It's directly comparable to sports like basketball, soccer, baseball, and softball. And when you take football out of the equation, women have a much higher rate of injury. So excluding football, and you look at the sports where women and men are participating, women have a higher rate. Boys also have the highest rate of needing surgery from their injuries. But again, when you take out football out of the equation, women have a much higher rate of requiring surgery compared to the men. So these are some of the disorders that happen more frequently in women. So you see spondylolisthesis, which is a slippage of the spine. You get stress fractures of the pelvis and the hip, patellofemoral disorder, non-contact ACLs, ankle instability, multidirectional instability of the shoulder, and swimmer's shoulder. And we're going to briefly touch on these. So again, overuse injuries in general, much more common in female athletes. There's a lot of different explanations, whether it be hormonal variation, muscle mass related to their overall body weight. Your ligament and tendon composition is a little bit different in women compared to men. Their nutrition and eating habits are different, and the role of menarche in these women athletes. So starting with the spine, which is my least favorite part. I don't do spine at all, but spondylolysis is found. Spondylolysis is a stress fracture of the pars interarticularis in the back, and it's found in about 6% of the population. There's an increased prevalence with activities of hyperlordosis. So in women, this is going to be your divers, dancers, gymnastics, anything where they're really extending their spine in an extensive way. So spondylolysis is a progression. So then you can get a stress fracture on both sides, and it will slip over time. That's a spondylolisthesis, where you'll see one vertebral body slip on top of the other. It's more likely in females, and usually in adolescents. So you see these in young girls, particularly the gymnasts. It's very common. Stress fractures in the lower extremity, much more common in women, and it's the most common injury that female athletes face. They have a much higher rate of getting stress fractures than any other injury that they're going to be exposed to. This is typically due to overuse, particularly in an amenorrheic athlete. So this is a classic athlete, what you would see, like a long distance runner, a marathon runner. These are the patients that you're going to see these pop up. So you have to have a high suspicion when you have a young woman come to see you training for a marathon. They're complaining of hip pain. I have a very low threshold for getting an MRI on these patients. ACL injuries get a lot of press, and particularly in the orthopedic world, we talk about these a lot because they're so much more common in women. We know the risk factors for ACL injury higher in women. There's a high incidence in the sports that are primarily at risk: soccer, basketball, skiing, and gymnastics. The incidence is reported to be 2 to 8 times greater than their male counterparts. And again, the proportion is higher in non-contact sports. So usually it's not a collision, it's a non-contact where they'll just be cutting and moving in a different way. There's a lot of different theories as to why this is. So there's different etiologies. There's intrinsic factors that we can't change and extrinsic factors. So we're going to briefly touch on all of these. There's some things that women can control, or that any athlete can control. So some of these intrinsic factors, well, there's knee laxity. So women have higher laxity in their joints than men. So, and it's been noted that women with laxity values greater than 1 standard deviation above normal had a relative risk of about 3 times higher than women with less knee laxity. If you take into consideration someone who has hyperlaxity, and you combine those with some of the other intrinsic factors, such as anatomy of having a narrow notch in their knee, or if you look at them with an increased BMI, you can see the risk of an ACL goes up significantly. So increased laxity with a narrow notch, they have a 17 times higher risk of getting an ACL injury. If you have a high BMI with laxity, almost a 40 times higher risk of getting an ACL injury with sports. So what am I talking about with the notch? I probably should have put that in there first, but there's anatomical differences in women's knees versus men's. And if you look at a male femur, let me see if I have a pointer. Do I have a pointer? Is this a pointer? Let me see. I don't know. I can use this pointer right here. But you can see that a male knee has a wider house. The notch is in between the 2 condyles. That's what we're describing. And the area in between the two is the space that the ACL and PCL live in. So if you have a wider intercondylar notch, there's less impingement of the ACL with activity. Women have that narrower notch, so theoretically can increase the shear force on the ACL with activity. We also have different receptors on our ACL than men. So women have estrogen, progesterone, and relaxin receptors on their ACL, and all of those can have an impact in how it responds. So estrogen, we know, can enhance tendon collagen synthesis, but it's been shown to decrease the cross-linking of the collagen and enhance joint laxity. Women have been shown to have decreased collagen or tendon collagen synthesis at rest and after exercise. So women tend to take a little bit longer to recover and might need more rest in between exercise sessions. So when you have a young girl going and doing 6 games at a showcase soccer tournament over a weekend, that's going to be harder for her to recover and get back. And women are more susceptible to fatigue. Hormonal variation. So when they've looked at whether the menstrual cycle plays a role, it does tend to. There's been some conflicting data on this. The best study, I think, was an NC2A study where they looked at all the women ACL injuries that occurred in the NC2A for several calendar years. And they found that women had a greater percentage of ACL injuries during the mid-cycle when their estrogen was peaking. So that makes sense. As the estrogen goes up, their ligaments get more lax, they're more likely to have an ACL injury. There's another conflicting report which shows in high school girls that potentially the risk is higher when they're actually on their menstrual period, that they have a greater incidence of fatigue. So there's some conflicting data there, but at the NC2A level, they showed a higher level. So then the question is, maybe putting young women on oral contraception, what if they're playing a high-level sport, is beneficial. That has not been proven yet. So the level of conditioning, so these are the extra, I'm going to switch to those are all intrinsic factors that are hard to control. Extrinsic factors, things we can control. Number one is the level of conditioning. So a study at West Point found that 60% of non-contact ACLs occurred during intramural sports versus the varsity sports. And that makes sense. Your varsity athletes are going to have greater strength and conditioning training and be at a more elite level than an intramural athlete. So the intramural athletes had a higher risk. I see that at Cal too. I've taken care of Cal for years, and I still work in the student health center there at the Tang Center. And I see, I take care of all the intramural athletes that come in and just the normal students that are out playing club sports, and they do have a very high risk of injury, always higher than the Division I athletes. Other biomechanical factors. So when they say that we run and jump like girls, there's some truth to that, okay? So female athletes have smaller knee flexion angles, greater knee valgus angles, increased quad muscle activation, decreased hamstring muscle activation during running and cutting as compared to their male counterparts. So all those factors have been shown to increase strain on the ACL. Now these can be conditioned and trained out, so you can teach women and young girls how to land appropriately, how to land from jumps, how to hold their legs in a more athletic position where they're not going to put as much strain on the ACL. And then BMI is also a factor. So women with higher BMI had this much higher incidence of non-contact ACLs. We know that. That makes sense. There's increased force as you move. Other extrinsic factors, again, there's this concept of overtraining, and I know Dr. Pandya, my partner, is going to talk about this in a bit, but there's been this professionalization of youth sports in the United States. So we've seen this huge increase in youth sports injuries due to the sports programs being moved out of the schools, right? So when I was growing up, you did your sports with the schools. You rarely, there weren't, unless you were a swimmer, there were no real club sports when I was growing up. If you wanted to play soccer, you played on your high school team. Now that's completely different. And now they actually kind of shun their high school teams because they want to be on these elite travel teams. And they, as we know, they compete year round. They go to these showcases where they're doing 10 games in a weekend. It's a $17 billion industry in the United States, so it's really hard to stop. As doctors, we know that this is bad for these kids. I'm a parent. I have 2 children. I'll never forget my 14-year-old son. At the age of 10, when he was 10, he was invited to be on this lacrosse team that involved us traveling to the East Coast 4 times in a summer. And I remember thinking, why would a 10-year-old? Why do we have to go to Maryland to play lacrosse? He's 10. It's one thing if you're in college playing, but it's kind of insane when you think about it. We did not join that team. So there's newer data, and these are some surgical considerations to think when you're guiding your female athletes, and you guys as primaries are going to see them and help direct them. New data suggests that women are unfortunately much more likely to have a re-tear of the ACL graft, so they're at more risk after they've had the surgery. So not only are they at a higher risk of getting it, they're at a higher risk of re-tearing it in the future, which is devastating. There's a lot of discussion about graft choice. Am I using the patellar tendon? Am I using a hamstring? Am I using a quad tendon? Quad tendon's kind of the new hot thing, which is exciting. There's one study that shows hamstring grafts were much higher, had a higher rate of failure in that age of 15 to 20. Other data refutes that and shows no significant difference, so it's kind of mixed. We do know that women who have a BTB graft, patellar tendon graft, they have a much higher risk of having pain on the front of their knee or kneeling pain. So I take a lot of those factors into consideration when I'm advising these patients. Do they have underlying patellofemoral pain? Do they have a history of increased laxity when I'm choosing which graft to use? There's a lot of push right now for augmentation. My partner, Alan Zhang, just published a great paper showing success with augmenting his hamstring grafts with sometimes it's a suture tape, sometimes it's adding an extra procedure. So I when I augment them in that high-risk young girl population, I like to put an ALL, and sometimes it's a lateral tenodesis, but all those things can help prevent the risk of re-rupture. So we're getting smarter with our surgeries as we go forward, and we understand that not all patients are the same. So again, you take a high-risk young girl who's going to go on and play college sports, that's a patient we want to add a little bit extra no matter what you're doing. So other studies, quad tendon is the new exciting graft. Quad tendon has been shown to have decreased re-rupture rates compared to hamstring autografts. The advantage of it, it's got the girth of the tendon. So if you imagine, thinking back to our physics days, our pre-med days, the strength of our grafts are proportional to the cross-sectional area. So it's actually important how much diameter that tendon has. And the quad tendon seems to have the highest, even more than a patellar tendon. And they also have very low morbidity. They don't get that bone pain from kneeling in the future. So that's kind of an exciting future thing. And again, this kind of shows the cross-sectional area of the graft. So you can see patellar tendon is actually quite small, 35 millimeters. Hamstring tendon tends to be 53 millimeters. Quad tendon, 62 millimeters when you do cadaver studies. So just in summarizing ACL issues, female patients have higher rate of ACL, higher risk of re-tear, much higher rate of post-traumatic arthritis as they age. So it's been noted to be as high as 87%. So this is what I'm seeing a lot of now, are these 30-year-old women coming in who had ACL injuries when they were 16, 17, 18, and their knees are destroyed. It's really hard for them because they are athletic usually. That's part of their identity. And you're looking at them, they need a total knee at 35. So moving on to patellofemoral pain. That's the bane of my existence. Who likes patellofemoral pain? It's very, very common. It's fine. It's just one of those hard problems to treat because we don't have a great surgery to treat it. You can tell when there's 8 million ways we treat it that we don't really know a good way to treat it. Our physical therapists are our best friends on this. The physical therapists do all the heavy lifting for patellofemoral pain. There's a lot of reasons women have more. So it can be limb alignment. They have increased aneurysm of the femoral neck. So you get this force on the patella. It's driving it outward. It has this tendency to want to go to rotate externally. Women have more external tibial torsion, more pronation of the foot, increased Q angle. So our hips are wider in relation to where our ankles sit. So we have an increased valgus at the knee, which will force that kneecap out. Women have a higher rate of patella alta, the patella sitting high. And again, the ligamentous laxity is part of it. So if our ligaments are overall loose, you're going to have increased subluxation and motion at the patella. So how do we treat it? Quad strengthening with an emphasis on closed kinetic chain exercise is really the workhorse. Like I said, our physical therapists are our friends that help us. You can try McConnell taping. There's certain orthotics that help push the kneecap in a little bit, or just wearing a knee sleeve can help sometimes. There's been muscle stimulation techniques that can help. And again, a lot of patient education. I myself have suffered from patellofemoral pain since I was about 15. It goes on and off. And it does hurt. It was interesting. The first time it really flared up, I was like, oh my gosh, this is horrible. And then I realized what my patients were going through. So it is very painful. It's hard because we don't have an easy surgery. When do we take people to surgery for this? Usually if they're grossly dislocating their patella. So we don't take them just for pain. We just take them if they're having gross instability where the kneecap is popping out of place. So that's why you might see, well, how come they're not doing anything about it? Because we don't have a good treatment. Shoulder instability also occurs in women, but the one we see more likely is multidirectional instability. Again, related to the estrogen and ligamentous laxity, women are more likely to have MDI. MDI meaning the shoulder will subtly sublux in all directions. So you can see it go to the front, the back, inferior, all these places. There's hypermobility. That hypermobility of the shoulder puts extra stress on the rotator cuff. So they're more likely to get rotator cuff inflammation or tendinosis at a young age. So when I see a young woman come into my office with rotator cuff inflammation or tendinosis, I think, oh, they must have some form of instability, because most 18-year-olds aren't getting rotator cuff problems yet. All right, we usually don't see just degenerative rotator cuff issues until they're 40 plus. So when you see it in a young patient, think they probably have some component of instability. Traumatic shoulder instability in women is very low. When you see that 90% of traumatic or the shoulder actually frankly dislocates and has to be reduced in the ER, 90% of that is in men, 10% in women. Women do tend to have a worse post-op outcome and a higher rate of repeat dislocations. And again, most likely due to their underlying shoulder instability. Again, when we diagnose someone with multidirectional instability, the mainstay of treatment is non-operative treatment. Our physical therapists are our friends. They're going to come in and help us fix those people. We work on scapular stabilization exercises and rotator cuff strengthening. So if their ligaments aren't doing it, you really want to increase the muscle bulk around their shoulder and let their muscle activation take over. Swimmer shoulder, commonly seen in California because we have so many robust swimming programs, is also much more common in women. And that is rotator cuff inflammation, tendinosis related to the act of swimming. They have this kind of nondescript shoulder pain. It's usually due to overdevelopment of the anterior shoulder girdle compared to the posterior. So they'll get this subtle instability. Hip pathology, we know that patients undergoing hip arthroscopy, women over 45 had the poorest outcome. Under 45, their outcomes were pretty similar to men. There are some anatomical hip differences between men and women. Women have smaller alpha angles in their hip. Their cam lesions are much more subtle. Most of the time in women, you'll see a higher rate of dysplasia causing hip pathology, such as labral tears, as opposed to the classic femoroacetabular impingement. You can see it in women, but it's much more common in men. There's more women that fail their hip arthroscopy. And so when you look at the number of people having a revision hip arthroscopy, 70% of them are women. So men tend to do better surgically. So again, therapy is going to be your first line choice when you have a woman with that problem. Ankle instability. Women, again, much more likely to have ankle instability and sprains. And they're also more likely, unfortunately, to fail surgical intervention. So we see this theme going with all these things. Women have more pathology and are more likely to fail, most likely because their ligaments have this underlying laxity. If you're covering sports teams, don't forget about your cheerleaders. They have the highest rate of catastrophic injury, being C-spine or traumatic brain injury, because they do this stunting. So it's something just to be aware of if you're covering a sports event, that you might be called upon to deal with a big injury like this. So cheerleading in high school and college accounted for 50% of all catastrophic injuries. So just some more medical issues that women face at a higher level. Iron deficiency due to the loss of blood during the menstrual cycle. Many female athletes are iron deficient. Restoring their iron stores is associated with an improved performance. Okay. Iron stores is one thing we check when people are getting repetitive stress fractures. You want to check their iron stores. Athletic amenorrhea, present in up to 20% of vigorously exercising women. Present in 50% of elite runners and professional ballet dancers. So this is a problem. We're seeing these women that stop having their menstrual cycle. It was initially thought to be due to insufficient amount of body fat in their body, but now we know the theory is that it's due to too little caloric consumption. So nutritional counseling is vital to get these women back up to speed. They can have an eating disorder, but this is actually less rare. Many of them just are over-exercising. They don't realize they're not eating enough for the volume that they're doing. And you can see eating disorders such as anorexia and bulimia in 15 to 66% of female athletes. Bone mineral loss can be seen after 6 months of amenorrhea that can resemble a postmenopausal woman. So it's important to educate young athletes about this problem. If they're not having periods, then, and I know, like, I have friends that were elite swimmers in college that were told that if they were getting their period, they were too fat. So this kind of thing, this kind of mentality can be passed down by the coaches and is wrong. 60 to 70%, as we know, 60 to 70% of your peak bone mass is acquired before the age of 20. So we need to be very aware of this in your young athletes. So it's good to ask. And a lot of times you ask, they're like, oh yeah, I maybe got a period a year ago and then it stopped. And it's important to be on top of it. Restoration of normal menses may retard their bone loss, but the bone already lost cannot be replaced. So it's important to catch it early. Again, the term female athletic triad was coined in 1991 to describe menstrual irregularity, disordered eating, and premature osteoporosis. This was revised in 2007 by the American College of Sports Medicine to focus more on the metabolic features of the syndrome. we see this in a higher percentage in non-competitive athletes, in aesthetic athletes, so athletes that are judged. So if you are a gymnast or a figure skater where you're getting a number instead of like running in a race and whoever wins, wins, they're at a higher risk of developing an eating disorder. So they also found that competitive athletes in other sports, it was somewhat protective for having an eating disorder. So female basketball, female soccer, they tended to eat and have less of a risk than the general population. So I think about this with my daughter, which sports I wanted. She was all into gymnastics. She's also going to be like 6 foot tall like me, so that wasn't a good choice for her. But anyway, concussion risk, incidence is higher in women. Women have increased symptom severity with concussions. There's a longer duration of recovery. Female athletes have twice the concussion risk compared to men. Girls soccer is second only to men's football. All right. Again, female athletes report more symptoms. There are inferior results with respect to visual memory compared to males. And women, on average, take a mean time of 6 days longer to initiate the return to play progression compared to men. So understand your females are good. And we don't know, there could be reporting bias or a sense of machismo in the men that they have to, I'm fine. And women are potentially more likely to report their symptoms. Other issues with female athletes, so is exercise during pregnancy safe? Yes, we want women who are exercising to maintain their exercise when they're pregnant. Other things just to consider, avoid exercise in the supine position after first trimester to prevent compression on the IVC, to make sure the baby's getting enough blood flow. And also just obviously stopping when they're fatigued, don't go to exertion, obviously avoiding contact sports. They need to increase their caloric intake accordingly and focus on keeping their core body temperature below 38 degrees. And then postpartum, they can resume gradually over 6 weeks. I have noted in my practice, a lot of women will come in with musculoskeletal complaints in that postpartum period as well. So when they're breastfeeding, their body still thinks they're pregnant in a way, so they have increased knee pain and issues. Exercise and aging in women. This is so important as we age. There's so many benefits to women being active as they age. I think the key, obviously, is encouraging patients to start young and stay active. We know that light weightlifting can retard bone loss. Balance training is important to prevent falls, which can be deadly. So Tai Chi has been shown to be beneficial for that. Yoga. But I encourage all women that are older. I have a lot of older women in my practice, and to maintain their fitness, to find something they like. Again, the decreased cancer risk, dementia risk, high blood pressure, cardiovascular risk, things you guys all take up, they're so important. And exercise is the key. I always find it fascinating. I practiced in Chicago, New York, and now California. And people here are so much more active, and we're so lucky. We have this vibrant young population that is really exciting to watch. But as they age, they stay active. So I have all these wonderful 87-year-old women that are out walking every day and lifting weights and doing things. And it's the culture here, and I think we're lucky to be doctors in this place. So in summary, female athletes, women get the same injuries as men, just there's several injuries that are much, much more common. And awareness of those injuries that more commonly occur in women is important for prevention and diagnosis. Look for your stress fractures in your long-distance athletes. Be aware of that. And thank you. And those are my little guys. And I'm open for any questions you guys might. Oh, the other thing I didn't mention, which I should just briefly mention, is that there's been a new push for women, and you guys would know this probably more than me, but to stay on hormone replacement therapy. And there was that cardiovascular study that came out in the 90s, and they said no woman should be on that. But now the current thinking is when women are perimenopausal, as long as they don't have risk factors like breast cancer and blood clots, to continue hormone replacement, which helps them decrease the risk of musculoskeletal injuries as they get older. There's also other benefits for their heart, blood pressure, other things as well. So anyway, yes. So, does anyone in the audience have any questions? Yes. Yes, if someone's having recurrent dislocations of the shoulder, yes, I definitely recommend an MRI. Yeah, you're looking for labral tears, and the younger people will often have a tear of the labrum. Sometimes they can get a rupture of their subscap rotator cuff muscle. And as people age, if they're 40 or older, the risk of rotator cuff tears as high as 50+%. So I'm a little more quick to get an MRI in an older patient that's having recurrent instability. But definitely younger people that are dislocating recurrent, those are surgical candidates. We want to stop them from coming out because they're going to keep damaging and increase the risk of arthritis. So, yeah, we get MRIs. Yes. Yeah, I go over all the options. I do all three types, and I'm comfortable with all three. But I look at there's a few things I look at. I ask them if they have a history of anterior knee pain, and if they do, I really try to steer them away from the patellar tendon graft. Okay, I look if they have underlying hyperlaxity, because if they have a lot of hyperlaxity at baseline, I may not graft on that patient, because that theoretically then they'd have decreased collagen binding in that tendon. Okay, so and then I depends on their age as far as cadaver or not. There's advantages to the cadaver in that it hurts a lot less. The disadvantages is that in young people, it's been shown to have a much higher risk of re-rupture. As high as 30% of them will fail if you use a cadaver graft in a young patient. So over the age of 30 probably doesn't matter, okay? But under 30, I really try to push them towards their own tissue, okay? So his question, I'll repeat the question. So he asked about all the overtraining going on with the kids and even in the young adults, 20-year-olds. And it is a horrible problem. I think Dr. Pandya, my partner is getting ready to talk, has probably written the best papers in the country on it. We see this evolution of these injuries, particularly in the last 10 years. And I've seen it from both sides as the parent, so the other thing is there's this push multi-sport athlete, it's better, it's safer. And I think there's some truth to that. It's because you don't just want to do baseball year round, okay? Because that's going to put too much stress on the same joints. But what I found when I was trying to have my own child as a multi-sport athlete is that the sports overlap by so much that it was causing extensive overuse. So I think you have to use common sense. You have to look and say, well, is him being a multi-sport athlete making him do 12 hours of these games on a Sunday and 12 hours on a Saturday, and then I have to run to practice for this sport, So I try to give I try to give my kids at least one day fully off a week. I think that's important that they get a day of rest so their bodies can recover. And I try to just I try to not sign them up for multiple sports at once. So I'm really, really aware of managing their load. They call it at the college level, they say we're managing the load of the athlete. And smart sports teams are constantly monitoring now how much their athletes how many plays they did over the weekend, how many reps they did, and then they'll dial them back in practice. So I'm personally doing that with my own kids. I'm like, okay, they had 5 events on Saturday, we're going to take Sunday off. So, but it is hard because the coaches will push, the teams will push, and you're given all this pressure. If you want to be elite, if you want to be at this level, that you're helping your kid by signing them up for all these things. And so you have to, I don't know how to solve that problem other than continuing to talk about it ad nauseum and supporting Nirav Pandya's work because he's great. Yes. Yeah, so the question was, there's a question online about how do we monitor these young women for signs of osteoporosis or they're losing essentially loss of calcium. So I will order a DEXA scan if I'm concerned. If they have a stress fracture at a young age with minimal output, usually the first stress fracture, I don't do that whole workup. But once they get 2, if this is a repeat problem, or if they're amenorrheic, then I will do a DEXA scan, and they can match for their age. All right, so you send them for a DEXA, and you're not matching them to 65-year-olds. You're matching them to someone their age, and they can tell you. And then you start calcium supplementation, and I think nutrition counseling is the key. We've got Lindsay Orbeta talking today about nutrition, and in these young women, it's so important. They're not getting enough food. I see that in my own son. He's not getting enough food for swimming. He's a year-round swimmer now. I'm constantly trying to give him milkshakes. Anyway, yes, good question. So have I seen a difference in return to sport for the different graft choices? Yeah, not really. That's a good question. And really, it's the soonest they're going to get fully back to sport is 9 to 10 months. And the reason they can theoretically, so a lot of them, they'll get sold an ACL by someone because, hey, you can go back faster if you do the patellar tendon graft. That's not necessarily true. The grafts themselves have to mature. So we can put the graft in and fix it however we want, but the graft goes through a process over that time period where it morphs into the collagen structure changes and it becomes more linear, becomes more like a human ACL. So we've taken tendon, we're taking patellar tendon, quad tendon, hamstring tendon, but we want it to be a ligament. So it will morph over time. And they found at 6 months, so the return date used to be 6 months. And there was a famous football player a few years ago, Adrian Peterson, who got back in the NFL at 6 months. And, there was all this, I feel that was the worst thing for all of us orthopedic surgeons because now every patient's like, well, Adrian Peterson went back at 6 months. And so we have to do a lot of counseling on that. He's a superhuman and was doing 4 to 6 hours of therapy a day. And I think they were lucky it didn't re-rupture because in that 6-month period, the graft itself so usually it's healed into place, it's solidly fixed, but the graft itself is pretty vulnerable. So the graft is actually about 50% as strong as a native ACL at 6 months. Once you let that go on to 9 to 10 months, the graft is about 95% the strength of a human ACL. So that's where those numbers come from, all right? Why we make them wait 9 to 10 months. We want that to morph into a ligament structure and regain the strength it should. It's not just letting it heal into the sockets on both sides. So that's where that comes from. So 9 to 10 months is pretty average whether I do quad, hamstring, patellar tendon. For a primary ACL, if I'm doing a revision, it's going to be slower, usually about a year. Yeah. Sometimes, yeah. I will use cadaver in an older patient, older being, usually 40 plus. I will offer it to them. I will still do their own tissue as well. I always like to use their own tissue. It's my personal preference, but if they really want a cadaver, I will offer it to them. But usually, definitely not in a kid. I really discourage them, the kids. The data is so clear that they have this much higher risk of re-rupture, 30% compared to 5% if you're 20 years old, So there's some you go to the sports med ortho meetings and they fight, and there's people that are like, it's malpractice to do that in a kid. We should just get rid of it. They should not even be allowed in a kid. They haven't gone that extreme yet, but I believe that we should not be doing cadavers in kids. So based on the data that's out there, the re-rupture risk is too high. Yeah, that's a great question, thank you. But there's been a lot of one of the changes in the last few years has been a lot of interest. Oh, I'm sorry, repeating the question. He asked about the psychosocial factors in female athletes versus men. And there's been a lot of research on this recently in the last few years that's come out. And there is a difference. Women tend to have a higher rate of depression, particularly younger girls, depression and anxiety related to their injury and throughout the recovery. So some programs have have given them some preemptive counseling and about their injury, and they've shown a better rate of recovery, and then there's issues with them returning to sport as well. There's a readiness factor, a psychological readiness factor, and women take longer than men to feel ready to get back. And that's an important component with ACL surgery, is do they feel ready, And I talk to my patients a lot about that. I know we're at 10 months. Do you feel like you can play soccer now? And, half the time they're like, I'm not ready yet. And you go, okay, so we give it a few more months. So, but yes, women take a little bit longer to feel confident. And maybe they're just better at expressing their emotions. Yes. That's a very politically charged question. He said, are women ready to compete with men? and I probably have my own answer, and then there should be a UCSF policy answer. So I want to be cautious about that. I think in some sports, yes, but I think there's clear intrinsic differences, in our training, in our hormonal variation that make it hard for them to be on the same page. I think so. Anyway, I'm going to stop. I don't want to get in trouble. It's a great. We can talk after the thing. Yes, Carlin. So great question. She asked about the break with COVID, and a lot of people took this extended period, including high-level elite athletes, then were off for a period of time, and how have I counseled them on their return, and dealing with that change. And I think that's a very real problem that we all saw. And now that sports have kind of normalized in a way, I think we're much more normal than we were even a year ago. We're seeing less of it. But when they came back, there was a huge, huge number of injuries because particularly the kids, they just wanted to ramp right back to where they were, and they were deconditioned. So huge number of ACL injuries. It was like ACL season. We could have called it, I don't know if we've written a paper on that. We should. The high incidence and bump in injuries. We saw some different injuries during the lockdown because everyone started cycling. So all of a sudden there were clavicle fractures everywhere. That was the one increased injury we saw. So during COVID, it was like our sports practices disappeared in a way because they weren't competing. When they came back, it was like we saw double the number of injuries that we're used to. High risk of overuse. So my advice to patients, whenever you've got a break, whether it's caused by an injury or you've taken time off, is that they just have to start gradually getting back into their stuff. So if they want to go right back to their level, they're going to fail or they're going to get injured. The football team I take care of now, the city college sports, we saw a huge number of hamstring pulls, all these musculotendinous issues, Achilles, just a huge bump when they came back. They were lucky to be able to continue conditioning throughout, but they didn't play any games. So the year they came back, then, it's kind of like everyone with the RSV and the flu right now. We're seeing this big bump of all these illnesses, maybe because none of us had anything for 3 years. So similar with sports injuries. So that's a great question. And I know Lindsay she asked about for female athletes that are potentially restricting their eating, particularly the endurance athletes, are there concrete guidelines? I usually ask my friend Carlin over there. Carlin, do you have a response to that? I know we look at their iron stores, so I'll usually order the panel and then refer them to either Dr. Chang or Nick or Carlin to help me work them up because there are things we look for, iron stores, their calcium, but as far as an actual caloric number, I think you have to look at their output, what they're doing, and so that's where our nutrition friends and colleagues can really help with that. So Carlin, do you have anything to add on that? Absolutely, yeah, no, there's, he's talking about the overuse of protein. As far as athletes, using that, and you're specifically probably talking about the creatine powder that the young men use. Yeah, so, the main thing is, can their kidneys handle it or not? And they all do. Most of those kids at the college level are taking some type of supplemental powder, and they have to be careful where they're getting it. A lot of it, if they're getting it from some shady guy, there can be hidden anabolic factors in there. So I always advise the athletes to be cautious where they're getting it. Most elite schools, Division I schools, will sometimes supply their own to the kids because they don't want them buying it on the street or buying it at a GNC store and they're taking something that they shouldn't, that would flag them on a test and rule them ineligible. As far as the renal function, it's something to think about. So that's where they get into trouble, right? Is that they'll get a bump in creatinine because they're taking too much. So, yes. Are we good? Okay. All right. Thank you so much for all your good questions and your attention. Appreciate it.